Thank you for joining us for day 2 of this virtual workshop on developing a patient-centered approach to optimizing veterans' access to healthcare services. We have a very full morning and midday, so I want to get right into the program. But before we do that, I need to give a few reminders and just a few process things so that everyone is fully informed as we move forward. I just want to remind you that this is an open, on the record session, and it is being recorded. The proceedings or the video will be available to the public at some time not too long after the conclusion of the workshop. As we are moving through the panel and the discussion this morning, if you have questions that you would like to pose to the panelists, you can put those in or look at the discussion box underneath the live stream. When you do that, I would ask that you include both your first and last name, your full name, and affiliation so that we know where the question came from. And any questions as well as the comments and presentations that are made over the course are or will be included and used to produce the workshop summary that I already mentioned. And we find the comments and the discussion particularly useful as we move forward and develop the summary. So again, thank you for joining us for day 2. Yesterday was quite a dynamic and informative discussion, I thought, and we're anxious to move forward. So with that, I'm going to turn the baton over to Jeanette, who is going to lead us through this first panel. Thank you, Jeanette.
Thank you, Ken. And I am interested in a very important topic, which has to do with how we provide access to healthcare services for special populations amongst our veterans. I'm excited to introduce to you a panel this morning and tell you a little bit about the types of special populations that are of particular interest to the VA. It's important for us to realize that there are a number of different populations who have particular needs within the veterans' populations. I have no disclosures. The total veteran population is actually predicted to decline over the next 20 years from about 20 million to a little bit more than 13 million. That decline largely will take place amongst those who we look at as non-Hispanic white veterans. But that means that the proportion of other racial and ethnic minority groups will, though it looks like it stays the same, will make up a larger percentage of our veterans' populations. When we think about minority veterans, that population is predicted to increase from about 23% of the total veteran population to almost 33%. And Hispanic veterans will increase to about more than 11% of the population. So that you see that we will need to be cognizant of the different needs of our changing veteran population. And the reason is because there's a wide range of healthcare disparities that we know exist in the general population as well as in our VA population, especially with respect to medication adherence, access to surgical procedures and other invasive procedures, and the many processes that are embedded in receiving health care. And disparities likely are affected by both quantity and quality of patient-provider communication, shared decision-making, and patient participation. We know that there is a certain segment of our veterans population who are battling substance abuse. Probably about 10% of our veterans are diagnosed with a substance abuse disorder, slightly higher than the general population. And the overall prevalence of substance abuse disorders among male veterans is actually lower, though, in many situations than the rate of their civilian counterparts. But they are greatly impacted by these issues. And it has consequences with respect to pain, to suicide risks, trauma, and homelessness. And we'll talk a little bit about that as you listen to our panel's comments. We also want to pay specific attention to our women veterans. We know that a cross-sectional survey that was done of women veterans, VA users, found that the reasons that most of them choose VA for their services have to do with affordability, women's health center availability within VA, quality of care, and convenience. We also know that about 31% of women veterans, and as opposed to 45% of male veterans, actually have access to public or private health care insurance. And when we sit down and look at what were the experiences of women veterans versus male veterans, we'll find that the largest cohort of male veterans served during the Vietnam era, while the largest living cohort of female veterans actually served since 9/11. And our female veterans are more likely to have completed some college. They may have a bachelor's degree or an advanced degree, and they are more likely to have had a service-connected disability rating, but then actually can have access to other services and can get their care elsewhere. So employed veterans, women veterans, when they are there, are more likely to work in management and business, science, and arts occupations than their employed male veteran counterparts. We also recognize that another special population in VA has to do with homeless veterans. And the term you hear is sheltered homeless individual veterans, or SHIV. You find that there are homeless veterans, unfortunately, are overrepresented among the general homeless population. We heard some discussion of that yesterday by Dr. Gelberg, and we learned that there are unique programs taking place in different VA hospitals to try to address the needs of our homeless veterans. The sheltered homeless individual veteran demographic characteristics were similar for a while, but they, however, are more likely to be white, non-Hispanic, non-Latino, and thus less likely to be a minority. But we realize that this can vary demographically from one region to another. Care use by homeless veterans has gotten a lot of interest, and we know that 25% of homeless and about 18% of non-homeless veterans reported active substance abuse. So there are some unique characteristics that we want to be aware of when we look at those of our veterans who are homeless. And when you realize that homeless veterans access primary care at higher rates and use specialty care plus primary care when they were able to have access, that reduced their emergency department usage. We'll hear some more about that as well. Other studies that have looked at care of homeless veterans have found that when they are able to have integrated care and are rapidly enrolled in primary care, they're going to more likely to receive more preventive services as well as primary care visits, and as a result, fewer emergency department visits. The other special population that you've heard some discussion about in yesterday's presentations are those who are rural veterans. And we realize that they have some unique needs as well. There are a higher rate of post-traumatic stress disorder, post-concussive syndromes, and alcohol issues. And so the mental health service utilization for our rural veterans is important, and it's correlated with higher education, PTSD, and lower mental health-related quality of life. Being rural predicts greater decline. So we really recognize the importance of paying attention to our rural veterans population because of those needs, as you can see in front of you.